Good morning, everyone. It is a pleasure for me to be with you, although virtually, and please allow me to thank the organizers for the most kind invitation. I will speak today about hot topics in AML and more specifically about what has changed or is changing in 2025 and 2026. I will focus on the data I think matters most for clinical practice right now, and I will go deep where the science deserves it. AML is changing fast, as you all know, and I would say that we are living through three major shifts at the same time. First, molecular risk stratification is now standard. The ELN 2022 classification is no longer just a research tool, it defines the treatment path from day one. Second, MRD, measurable residual disease, is moving from the research laboratory to our daily clinical decisions, guided by the new ELN 2025 MRD framework. And third, we are moving away from a single backbone therapy towards targeted combinations, triplets, and menin inhibitors. And it is also worth noting that we have more than 10 FDA approvals in AML since 2017. Unfortunately, EMA approvals are lagging behind, and our patients in Europe fill this gap. This is the roadmap for the next 20 minutes or so. I will begin with Ven plus Aza in fit patients, and we will discuss the paradigm trial. Then I will move on to menin inhibitors. We will discuss triplet combinations, especially in NPM1 mutated, KMT2A rearranged, and FLT3 mutated patients. And fourth, I will highlight key practical messages from the latest ELN 2025 MRD guidelines. Finally, I will close with a short horizon scan on immunotherapy, TP53, and what we should watch next. So let me start with the paradigm trial. This was a phase 2 randomized study with 172 patients. Median age was 64 and 72% of the patients had adverse risk disease. The trial ran across 9 US centers. The question was, can venetoclax and azacitidine compete with intensive chemotherapy in fit patients? And the answer was striking. Event-free survival was 14.5 months with venetoclax plus azacitidine versus only 6.2 months with intensive chemotherapy. The overall response rate was 88% versus 62%, and composite complete remission was 81% versus 55%. And here is what I find very important from a human perspective. Patients who received Ven plus Aza spent only 15 days in hospital compared to 36 days with intensive chemotherapy. 0 admissions on ICU versus 9.8%. And these are not just numbers, they represent a very different quality of life experience for our patients. However, the paradigm trial leaves important questions open. Overall survival was not statistically different, and there was crossover between the two arms. Maybe this confound, of course, the signal. The CR rate difference, 59% versus 50%, was not statistically significant. Critically, the trial excluded FLT3-ITD, CBF-AML, and NPM1 mutated patients under the age of 60, and we all know that these are exactly the patients where intensive chemotherapy works best. Last but not least, there is no phase 3 confirmatory trial announced yet. Andrew Way has framed the new clinical question very well. Which fit patients should actually receive less intensive therapy? This is the conversation we are now having. Two further data sets put Ven plus Aza in perspective. First, the well-known Viale A trial and the 43-month follow-up that was announced showed that the hazard ratio improved from 0.66 to 0.58, with a median overall survival of 14.7 versus 9.6 months. Importantly, approximately 50% of the patients were long-term survivors. Therefore, there is a real tail on the Kaplan-Meier curves. But REVIVE, the real-world study with 207 patients, gives us a reality check. There was a 60-day mortality rate of 14% compared to around 5.5% in the VIALE-A trial. Moreover, dose interruptions occurred in 65% of real-world patients, and therefore the message is really clear. The trial outcomes and the real-world outcomes are different conversations. Therefore, we need to remember this when we inform our patients regarding their treatment choices and what to expect. Another important question is who benefits most from ven plus aza? The donor group published a useful 4-gene model in Blood in 2024. 4 genes can actually predict outcomes: TP53, FLT3-ITD, NRAS, and KRAS. Patients who are TP53 wild type without FLT3-ITD and with wild type KRAS and NRAS are the ones that have best outcomes, with a median overall survival of 26.5 months. Those with TP53 wild type but carrying FLT3-ITD or a RAS mutation have intermediate benefit, around 12 months, and those with TP53 mutations, as we know very well, would do very poorly with a median overall survival of only 5.5 months. This model helps us have better and more personalized conversations with patients at diagnosis. Before we leave this section, let us briefly understand why patients relapse on venetoclax. And there are several mechanisms that have been proposed. The main mechanisms are BAX mutations that present in 17% of relapses and disable the apoptotic pathway, the MCL1 upregulation, which allows cells to escape apoptosis, the RAS-MAPK pathway activation, which bypasses the need for BCL2, and the monocytic differentiation, a lineage switch to a venetoclax-resistant phenotype. And FLT3-ITD acquisition at relapse is another mechanism that has been suggested. I highlight this slide because it directly connects to menin inhibitors, since menin inhibition can overcome venetoclax resistance by downregulating MCL1 and upregulating BAX. And this is the biological rationale for the triplet combinations we will discuss next. Nowadays, we have 4 menin inhibitors in clinical development. Revumenib received FDA approval in November 2024 for KMT2A rearranged patients and again in October 2025 for NPM1 mutated AML patients, of course in the relapsed refractory setting. Ziftomenib was FDA approved in November 2025 for NPM1 mutated AML, again relapsed refractory setting. And regarding bleximenib, we have some phase 1 and 2 data, and we have the phase 3 ongoing trial, the CAMELOT-2 trial, which is running in Greece as well. Regarding enzomenib, phase 1 and 2 data were presented at ASH 2025. And I think the critical point for all of us in Greece and Israel is that none of these menin inhibitors are EMA approved. Access is limited only to named patient programs, compassionate use, or clinical trials, if and wherever these are available. Therefore, there is a real equity issue compared to the US. Now, let's see how these agents perform. Looking at monotherapy efficacy in the relapsed refractory setting, Composite CR rates are in the range of 20 to 33% across all agents. Overall response rates range from 35% for ziftomenib up to 63% for revumenib in KMT2A rearranged disease. Importantly, responses are real but short-lived. The median duration is only 4 to 6 months. The bottom line is that single agents provide meaningful responses, but combinations are clearly needed to deepen and sustain those responses. Safety is another important issue when using these agents. Differentiation syndrome, which we should think about as the menin inhibitors are equivalent of what we see with IDH inhibitors, occurs in 26 to 33% of patients any grade, with grade 3 rates around 12 to 13% for revumenib and ziftomenib. Regarding management, we should first of all early recognize the syndrome and then start as soon as possible dexamethasone and hydroxyurea, especially when leukocytosis is present. For QTC, revumenib has a 36 rate of any grade prolongation, 17% grade 3 or higher. Ziftomenib shows minimal QTC signal and bleximenib has no QTC signal at all, which makes it more attractive for combinations. Always, we should perform an ECG baseline whenever we start our patients on any of these menin inhibitors and, of course, monitor the patient regularly. Moving now to frontline combinations, the BEAT-AML trial tested revumenib plus azacitidine plus venetoclax in 43 newly diagnosed patients, older of course. The median age was 70 and patients were up to 92 years, all unfit for intensive chemotherapy, with NPM1 mutated or KMT2A rearranged disease. The results are really impressive. Overall response was 88.4%, composite CR 81.4%. In the KMT2R rearranged subgroup, the overall response was 100%, 9 out of 9 patients responded, and MRD negativity was achieved once again in 100% of the patients, at least of the 37 evaluable patients. The median overall survival was 18 months for KMT2A rearranged and 15.5 months for NPM1 mutated patients, with a 1-year overall survival of 63%. The toxicity signal includes grade 3 or higher febrile neutropenia in 26% and QTc prolongation in 12%. This triplet has now moved to the EVOLVE-2 phase 3 trial. The COMET-007 trial tested ziftomenib plus azacitidine plus venetoclax in 40 newly diagnosed AML patients with NPM1 mutation. The CR was 73%, composite CR 86%, overall response 89%, and MRD negativity by NGS was 68%. The toxicity profile was very clean. Differentiation syndrome in only 2.5%, less with the combinations. QTc prolongation in only 2.5%. In co-mutated subgroups, FLT3 and IDH mutations, the composite CR rates were 77% and 89% respectively. The trial has led to the COMET-017 phase 3 confirmatory trial that is going to start in Greece soon. Looking now at BEAT-AML and COMET-007 side by side, we can see that both show composite CR above 80% and high MRD negativity in NPM1 mutated and KMT2A rearranged settings. BEAT-AML has higher MRD negativity, 100% versus 68%, but COMET-007 has much lower differentiation syndrome and QTc rates. Of course, we cannot directly compare them, different populations, different assays, different follow-up. What we can say is both strategies are compelling and phase 3 data will be critical. Now, resistance. Approximately 40% of patients develop resistance to menin inhibitors. The emerging mechanism is somatic mutations in the MEN1 gene itself at the binding interface between the menin protein and the inhibitor. There are several key mutations that have been imported, including M327I, M327V, G331R, and so on and so forth. These have been documented in about 39% of post-revumenib cases. Critically, they can appear within just 2 therapy cycles. That means the first 8 weeks. For post-ziftomenib or post-bleximenib patients, MEN1 mutations have not yet been documented. But of course, this may reflect shorter follow-up or different binding. So a new question arises: can we overcome resistance by switching between menin inhibitors? The answer appears to be yes, and the analogy to CML, where we switch TKIs based on mutation profile, is obvious. Bleximenib retains binding with the M327I mutation. Ziftomenib retains binding with T349M mutation, and so on and so forth. This, the ability or the strategy of switching has been demonstrated clinically as well. It was published in Leukemia in 2026 in a KMT2A rearranged patient who became resistant after 17 cycles of revumenib and achieved remission after switching. The principle, therefore, is match the switch to the mutation. Looking forward, second-generation agents like BTC86 appear active against all MEN1 mutations with lower QTc and KAT6, KAT7 inhibition. Moving now to triplet combinations for FLT3 mutated disease, the AZA plus venetoclax plus gilteritinib triplet has now very encouraging long-term data. Actually, this study was in the frontline setting. 30 newly diagnosed older or unfilled FLT3 mutated patients received the triplet combination with a median follow-up of 41.5 months. This was published in Hematologica. The results were as follows: 100% achieved CR/CRi or marrow leukemia-free state, and the CR rate was 90%. MRD negativity was 93%, and the median overall survival was 29.7 months with a 3-year overall survival of 46%. FLT3 TKD patients did even better with a median overall survival of 39.3 months, and these are remarkable numbers for older patients. Now, comparing the triplet to the doublet in the same trial context, the triplet showed CR of 67% versus 32%. Composite CR again is better with the triplet, and the same applies for MRD negativity, all highly significant. Therefore, the advantage is consistent across all response metrics. But here is one of the most important and sobering findings in AML biology today. When patients relapse after FLT3 triplet therapy, 65% of relapses are FLT3 wild type. What happens is that the triplet eliminates the dominant FLT3 mutated clone very effectively, but residual minor clones, subclones persist. So at relapse, new RAS pathway clones emerge, and the majority of relapses are driven by polyclonal FLT3 wild type disease. Therefore, the clinical implication is critical, FLT3 ITD monitoring alone is insufficient. We need also NPM1 PCR monitoring and flow MRD alongside with the FLT3 NGS MRD monitoring. And from the LACE-WING trial, we learned that venetoclax, not just the FLT3 inhibitor, creates the apoptotic priming, and this matters. So in general, biology matters. Relapse is usually in AML a new disease, and we need to check the mutation profile upon a relapse once again. Regarding now the future in the menin inhibitor landscape, there are 3 phase 3 trials now currently enrolling, as I have already mentioned. The COMET 017 frontline ziftomenib in NPM1 mutated and KMT2A rearranged AML, and the first patient was enrolled in September 2025. The CAMELOT 2 study is again enrolling in unfit patients. We have bleximenib plus ven plus aza. Of course, the control is ven plus aza, and this is expected to be completed in June 2029. And Evolve 2 is the revumenib plus aza plus ven in the frontline setting, pivotal trial again now enrolling. Moving now to the ELN 2025 MRD guidelines, very recently published in Blood. They represent a major step forward. The Working Party achieved consensus on 53 of 56 recommendations. The most important structural change is the new 3-tier MRD burden classification. MRD negative means no detectable disease. MRD low level positive, disease detectable but below the traditional positive threshold, and MRD positive, disease above the traditional threshold. This is modeled on CML. There are also 3 qualitative response categories: optimal, meaning MRD negative, and we continue treatment as planned; warning, meaning MRD low level positivity, continue but repeat testing in approximately 4 weeks; and high risk of treatment failure, meaning MRD positive at the end of treatment. And at this point, we need to consider urgent intervention. This framework transforms MRD from a research endpoint into a clinical decision tool. The guidelines also specify assay-specific cutoffs, which is very important practically. For NPM1 qPCR in peripheral blood after 2 cycles, negative means less than 0.001%. MRD low level means between 0.001 to 0.01%, and positive is considered above 0.01%. For bone marrow at end of treatment, the cutoffs are different. For multi-parameter flow cytometry MRD, the positive threshold is 0.1%. FLT3 ITD by NGS has only negative versus positive categories. There is no low-level positive category. And 2 additional key messages: pre-transplant MRD positivity is not a contraindication to transplant. This is recommendation A13. And another message: gilteritinib maintenance is effective in MRD positive patients around day 30 post allo transplant from the Morpho subgroup analysis. Last but not least, TP53 mutated AML remains the unsolved problem in our field. All standard intensive approaches have failed to translate into survival. The distinction between biallelic and monoallelic TP53 matters, as established by ELN 2022. Ven-based approaches achieve high CR rates, but overall survival remains poor, as we previously mentioned, around 5 months. The cytarabine 10 plus ven gives CR of 57%, but once a year overall survival is poor. And eprenetapopt APR246 plus ven plus AZA once again shows a good signal in terms of response, but it's not a solution. Magrolimab, as you know, was promising, but remains on hold due to safety issues. So the takeaway is uncomfortable but honest. Responses are achieved, but survival remains dismal. TP53 remains unsolved. A very brief look at the immunotherapy horizon. Of course, gemtuzumab ozogamicin is approved and standard in CBF AML, but underused. CAR-T for CD33 and CD123 shows CR up to 66%, but myelotoxicity remains the major barrier. CAR-NK are promising, targeting CD33 and NKG2D, with CR of approximately 60% with cord blood CAR-NK at day 28, with a lower CRS, and importantly, they are off the shelf. CLL1 targeting has the best selectivity index with low expression on normal stem cells. Therefore, we expect lower myelotoxicity. The bottom line, immunotherapy in AML is real and coming, but is still years away from routine clinical practice. And I would like to spend a moment on the access gap, because this affects all of us in Europe directly. As I mentioned in the beginning of my talk, revumenib and ziftomenib are FDA approved, but not EMA approved. Therefore, European patients can access these agents only through named patient programs or clinical trials. So our focus must be to close the gap with trials and, of course, with advocacy. Putting it all together, the AML treatment algorithm in 2026 is branching. First branch, molecular testing at diagnosis, is no longer optional. It defines the treatment path from day one. Ven plus AZA is the backbone for unfit patients, and Paradigm now challenges this also for fit patients. Third, triplets with a targeted agent show deeper responses, but of course phase 3 confirmation is pending. Fourth, menin inhibitors are the newest class with real efficacy. Access is the bottleneck in Europe, and of course we expect results in first line with combinations. And fifth, MRD-guided decisions are now codified in ELN 2025, and we should apply this framework. So 5 things to take home from this talk. 1, Paradigm. Ven plus AZA matches or beats intensive chemotherapy in fit AML, but phase 3 is needed. 2, menin inhibitor combinations achieve composite CR above 80% and high MRD negativity. 3, we have phase 3 trials now enrolling, and we are very happy that we have these trials in Greece as well. 3, FLT3 triplets give 3-year overall survival of 46% in first line. However, 65% of the relapses are FLT3 wild type, and we should be aware and we should monitor these patients beyond this mutation. And of course, we need to learn the new ELN 2025 MRD guidelines, since now it introduces the 3-tier system with qualitative responses. And as I said, regarding menin inhibitors, these are only available through the clinical trials. Therefore, we are truly in a transformation in AML. The science is moving fast, and our patients really deserve to feel it. I hope that this overview was useful. I'm really sorry that I'm not there with you to receive any questions. However, you can reach me at my email. And at this point, I would like to thank you very much for your attention.